2002. She passed away in February 2020, just a few weeks before the pandemic started. So to deliver the Professor Lata Kumar lecture, we have Professor Etsuko Suda, and she will be talking on her pet subject and on which she is a world authority, that is the long-term management of giant coronary aneurysms in Kawasaki disease. There is no one more experienced, more distinguished than Professor Suda to talk on what happens to giant coronary aneurysms in Kawasaki disease. Professor Suda, please.
Mr. Chairman, ladies and gentlemen, I appreciate to speak at this section. I am honored. The title is Giant Coronary Artery Aneurysm, Long-Term Fate. First talk is characteristic and changes of coronary aneurysm. In our 1981 study, coronary artery dilatation occurred in the 9th illness days, and coronary aneurysm appeared on the 11th illness days, while coronary aneurysm appeared up to the 17th of illness. We must know that the time of coronary artery formation is later than the time of alleviation of fever. We can see clinical course of a 6-year-old boy seen 1996, the initial IVIG resistance. He had very severe inflammation. CRP exceeded 30 milligrams per deciliter, and fever persisted for 11 years. We can see his serial echocardiography of right coronary artery are shown in enlarged progressively. Coronary artery was dilating until achieved giant status, CAA, at 20 days illness. Further, serial echocardiogram of the left coronary artery are shown with dilatation of left anterior descending artery. This slide shows his coronary angiogram at 28 illness days. He had bilateral giant coronary aneurysms. This slide shows a patient with a giant aneurysm. Severe localized stenosis of the LAD was detected 7 years after KD. In same patient, the diameter of CAA was decreased 7 years after the onset of KD. He is a 16-year-old male. Coronary angiogram is shown. Coronary angiogram at 2 months after KD are also shown. He has been asymptomatic. He has taken warfarin and aspirin. Most giant aneurysms, more than 8 millimeters, persist many years after the onset of KD and are likely to evolve into stenotic lesions. On the other hand, regression of moderate-sized coronary aneurysm is quite frequent. In the left, showing the finding of 2DE and CAD in 1 month after the acute phase. On the right, those in 1 year after the onset are shown. In 1 year after KD, small aneurysms are detected by 2DE. On the other hand, it's almost normal coronary artery, although there is irregularity of coronary artery wall. There is a slight discrepancy in the regressed aneurysm between 2DE and CAG. We can see outside of coronary artery by 2DE and the inside of vessel CAG. These pictures are left coronary arteries of the same patient. 1 year after KD, slightly dilated coronary artery is detected by 2D and CAG. The remodeling of coronary aneurysms caused by KD is very interesting. Usually, most small and moderate-sized coronary aneurysms regressed within 1 year after the onset of KD. We see a case presentation. An 11-year-old male had KD at the age of 9 years. In the left, CAG 2 months after the onset of KD. A giant aneurysm of the left coronary artery is shown. In addition, wall thickening is detectable in the aneurysm DSCT in the right. In regressed CAA and persist CAA, intimal thickening was detected. Here is another example patient with localized stenosis due to severe intimal thickening 2 years after the onset of KD. Next, we can see localized stenosis in the left CAG, giant aneurysm in the LLD, and small aneurysm in the bifurcation of the LCA and left circumflex. Localized stenosis occurred just proximal portion of aneurysm of the LAD. Further, in this patient, localized stenosis has gradually progressed over more than 20 years. Furthermore, in this patient, localized stenosis has gradually progressed over more than 20 years. At the age of 40 years, severe calcification was detected in both giant aneurysms by CT imaging. Localized stenosis occurred with coronary artery calcification many years after the onset of KD. Calcified aneurysm in the proximal portion is characteristic of coronary artery lesion caused by KD. This patient had acute KD at the age of 3 months old. These pictures are coronary angiogram 2 months and 1 year after the acute KD. They are giant aneurysms. 5 years after acute KD, the diameter of both giant aneurysms was decreased. Nine years after acute KD, the aneurysm in the right coronary, right coronary artery was occluded. On the other hand, collateral artery from left circumflex to the right coronary artery developed. This patient, in the same patient, coronary angiogram of the RCA was shown. In this patient, localized stenosis progressed over many years. If myocardial ischemia developed, we planned an intervention for localized stenosis. However, asymptomatic occlusion was detected at 27-year-old. Collateral artery from LAD to LCX, LAD and LCX to RCA were developed. This slide shows coronary angiogram 2 months and 1 year after the onset. After 14 years, CT angiogram indicated calcification in the proximal portion of the LAD. Myocardial ischemia was detected in technetium myocardial perfusion imaging. Coronary angiogram showed severe localized stenosis of the LAD. Thrombus in coronary aneurysm of the left coronary artery was detected by two-dimensional echocardiography. A coronary angiogram showed an occluded left circumflex. Warfarin was added to the aspirin C was receding. The cause of acute coronary syndrome by atherosclerosis in adult in plaque rupture. In contrast, acute myocardial infarction in Kawasaki disease is caused by coronary artery occlusion due to thrombus. This slide shows the interval from the onset of acute KD to initial myocardial infarction. Half of patients had myocardial infarction within 6 months. It is said that thrombus formation occurs when 3 factors of ill health exist. Acute myocardial infarction after KD in most patients is caused by sudden coronary occlusion due to thrombus in the giant aneurysm triggered by Wilfield's 3 factors for thrombus. First, endothelial dysfunction. The injured coronary artery wall due to severe acute vasculitis. Second, turbulence or stress within giant aneurysm. And third, hypercoagulability due to abnormality of blood coagulation factors after KD vasculitis. The 3 factors manifested in the first year after KD. Acute myocardial infarction after KD in most patients is caused sudden coronary occlusion due to thrombus in the giant aneurysm. This patient had an inferior myocardial infarction 1 year after the onset of KD. The right coronary artery was occluded. After 4 years, segmental stenosis was detected. Segmental stenosis was often found in recanalization after asymptomatic occlusion. Furthermore, it is suspected that segmental stenosis results from coagulation and fibrinosis in giant aneurysm. Segmental stenosis was often found in segmental stenosis is characteristic of coronary artery lesion caused by KD. It's suspected that they occur in children within a few years after acute KD. This slide shows localized stenosis detected 18 years after KD, after regression of moderate-sized CAA. Localized stenosis can occur many years after regression of coronary aneurysm. Furthermore, acute coronary syndrome can occur in adult patients with regression of large aneurysm. Coronary artery lesion caused by KD is shown. In stenotic region, there were localized stenosis, segmental stenosis, and occlusion. Aneurysms are often found in branching site. In summary, first, giant aneurysm occurs the proximal portion of the major coronary arteries. Second, thrombotic occlusion and segmental stenosis typify the first year of acute KD. Third, progressive coronary wall thickening with calcification years and years later. Fourth, asymptomatic occlusion due to well-developed collateral arteries. There are morphologic changes of coronary arteries depends on degree of injury sustained by the coronary artery wall in the acute phase, vasculitis phase. Second talk is outcome in patients with giant coronary aneurysm. The study involved analysis of 60 patients who had had previous myocardial infarction. The distribution of interval from onset of acute KD to initial myocardial infarction is shown. The median was 7 months after acute KD. The 30-year survival rate in this study was 63%. 15 deaths occurred. Sudden unexpected deaths in late period occurred in 6 patients. Survival rate are shown and depending on successful reperfusion. This difference is significant. In the next slide, the survival rate is shown depending on their left ventricular ejection fraction, post-myocardial infarction. The survival rate for the low LVEF group was low. Ventricular tachycardia free rate after myocardial infarction is shown in this slide. It would decrease 10 years after myocardial infarction. In this slide, the relationship of ventricular tachycardia free rate to the finding of larger isotope myocardial perfusion imaging are shown. The ventricular tachycardia free rate was low in the non-viability group. In this group, sudden unexpected death in the late period occurred. In summary, the outcome in patients after previous MI was also determined by the LVEF. Non-viability of the myocardium in the infarct area can induce fatal ventricular arrhythmia in the late period after previous MI. Next, here we see the outcome in patients with giant aneurysm. The incidence of stenotic lesion in the right coronary artery is shown in this slide. The incidence of stenotic lesion was significantly increased in the late period. In the incidence stenotic regions in the L3X was significantly lower than in the RCA and LAD. The overall survival rate in patients with the giant aneurysm at 30 years was 90%. The 30-year survival rate for bilateral GA was significantly lower than that for unilateral GA. The overall cardiac event-free rate in patient GA at 30 years was 36%. Note that the 30-year CE-free rate in patients with bilateral GA was significantly lower than patients with unilateral GA. The unilateral GA group consists of patients with GA in the RCA or LCA, and bilateral GA means the patient with GA in both coronary arteries. Furthermore, the 25 survival rate in post-AMI was 49%. The 25 survival rate in post-CABG patient was 92%. Furthermore, the 25 survival rate in post-CABG patient with a history of AMI was 74%, and for those without AMI was 100%. In summary, and not surprisingly, the outcome was significantly worse for bilateral GA compared with unilateral GA. The occurrence of myocardial infarction affected on the outcome in this population. In conclusion, myocardial involvement in patients with CAL caused by KD affects on the outcome, and it is the most important factor in the occurrence of late fatal ventricular arrhythmia. Appropriate measures to predict myocardial infarction will greatly improve the long-term outlook for these patients. Thank you for attention.
Thank you, Dr. Suda. Although after invited lectures, we generally don't have questions, but since there is a lot of time available, and since there are many cardiologists sitting in the audience, so we could open up the session for some questions. Dr. Devan.
Thank you for this wonderful talk, and we are quite mesmerized. And I just wanted to ask, when we are having children with moderate to large aneurysms, what are the factors which will give you the indication that this child needs a cath, that this child should go for an angiography? Not always we can do the stress testing, not always possible, especially in small infants. So clinically or by cardiac markers, is there anything that would tell us that other than the normal troponin, etc., is there anything that would indicate that this child will need a catheterization sometime soon?
Sorry. One more.
Small children, difficult to do stress testing.
Yeah.
So, if they have moderate to large aneurysms,
Yeah,
then what would make us think
yeah.
that this child would need cardiac catheterization soon? Even if the children are small, because it's very difficult to do angio
Yeah.
in small children.
Yeah.
So when would you really go for a cardiac angio with the children, even if they're small, if it's always small children?
In recently to CTA angiography is recommended. In past, coronary angiogram was performed, but now CTA angiogram or MRA is recommended.
So we would first go for the CTA and then depending on the findings or a cardiac MRI, and then we will decide on the angiography. Like on the invasive angiography.
Yeah, the diameter of maximal diameter of coronary arteries to 6 to 8 millimeter, more than 6 to 8 millimeter is candidate.
And for going for how soon, maybe around 1 year time, we should do a cardiac catheterization.
To localized stenosis is detected, precisely localized stenosis is detected in coronary angiogram. For indication of CABG, I recommend it. Thank you.
For a given size of giant aneurysm, so the different vessels have different rate of stenosis. Like the stenosis, this rate is more high with the LNCA or LAMP or RCA. So do you have any observations like that? For a given size of giant aneurysm over a period of years, is there any difference in the stenosis rate or calcification rate depending on the vessel input? So, any observations like that?
Yeah, to severe calcification, with severe calcification, but stenotic region is not always detected. The end to severe calcification is a marker for follow-up in outpatient clinic.
I think the question is stenosis more common in right coronary artery, LMCA, left anterior descending? After a giant aneurysm,
Yeah,
will
to
stenosis be more common in one of the three coronary arteries?
yeah, but
Right, Guru?
to occlusion of the right coronary artery was occlusion of right coronary artery is likely to early 5 years after Kawasaki disease, and stenosis of left anterior descending is gradually after 10 years.
So you meant to say RCA?
RC
Stenosis occurs a bit early than the left coronary.
Yeah, to occlusion, usually occlusion of the RCA is asymptomatic in patient. Sorry.
With the new therapy, with primary intensification of therapy, after giving cyclosporine plus IVIG, so does the giant coronary artery aneurysm outcome changes?
Yeah. I don't know about that.
Usually the migraine infarction it will occur, most of them occur within 6 months of first year of life. So your recent experience, have you seen any changes when you have used more drugs, not only IVIG, associated drugs?
Yeah. Sorry, I don't know about that. Sorry.
I just want to know your experience about which artery you find the giant aneurysms common. Like recently last year or this year. And what is the usual course of giant aneurysm? Is it different in different arteries? Or follow-up?
Yeah.
The question is, giant aneurysms are common in which coronary artery? RCA, LCA, LAD? In which coronary are the giant aneurysms most common?
Yeah. And RCA, the incidence of RCA and LAD are almost same, but incidence of LCX is small. Small.
And ma'am, does it differ, the course of the giant aneurysm, does it differ according to the artery involved? I mean, dilution of aneurysm, when you are following the aneurysms, when the person dilution comes, does it differ in the different arteries? I mean, the median time interval, when it becomes median aneurysm, long time or small. The deviation, does it differ according to arteries? What is your experience?
Yes, the question is that if there is a giant aneurysm, does it make a difference in regression, whether RCA will regress more than LMCA or LAD?
And about that, I don't know. I will try the study.
Come to the mic because it's being recorded.
So the medical group, they reviewed their past echoes and they did the Z scoring of those echoes. And they observed which coronary regress faster. So it is LCX, the last one is LMC. And obviously the size also matters. But usually LCX regresses faster than the LMC is the last one to regress. That's number one. Number two, for the Supreme story, again, ma'am herself had a study. The size at second month from the onset of illness has a correlation in the long term regression rates of the aneurysms. So, if you intensify the therapy, at second month itself, you may have a arrest of worsening of the aneurysms. In that way, it has implication in the long term outcomes of aneurysms. So, she herself had a study, I think it only 20.
Rhythm.
And do you use beta blockers routinely to all the patients with giant aneurysm?
Yeah.
Do you use beta blockers
Yeah.
in all patients with giant aneurysm?
No, no. I used beta blocker in low left ventricular ejection fraction cases.
We had a patient with a giant aneurysm in which some remodeling had occurred, but I think around 8 years down the line, this patient developed a stenosis, which unfortunately we didn't pay much attention to. We didn't take notice of that. So this child, he was around 40 years old. He was very fond of running. So he went for a run early in the morning and dropped down while running. Now, retrospectively thinking, I think we should have got some intervention done. But it escaped us. It just escaped us. So this was a child with, in fact, he had several giant aneurysms, but in one of them he had developed stenosis. Dr. Devdatta, if suppose you have to get an intervention done, how comfortable are you in getting interventions done in children with Kawasaki disease? What is the local experience in India?
Sir would be directed to answer these questions, but from my experience, they are very limited because especially 1 to 2 children, 1 to 2 years of age, the intervention team is very, very skeptical about intervening in the organs. But if the child has got serious stenosis and has got disruption and has pictures of MRI, then we have to give it a try.
How many CABDs have been done in Calcutta and Kawasaki disease?
So I think it has been done 3 in NH, of which only 1 I had witnessed when I was a resident over there. The child had come, it was a 9-year-old boy who had come with severe erectile dysfunction, and they found that the entire artery was totally fed by collatus. So, underwent a bypass that is being done now. The other 2, I think, Dr. Vatas have
He's not here.
Yes.
Oh, sorry.
So basically, from the giant
You have to
aneurysms,
come to the mic.
If you have the giant aneurysms, so in our small experience over the past 20 years, we had 3 CABDs. One was a 9-year-old boy. That boy basically had a Kawasaki disease at about 2 years of age. And we diagnosed the child as a dilated cardiomyopathy. He came at 2 years of age. So we retrospectively we saw, we asked the mother, and she gave a very vivid history that he had a lesion very similar to Kawasaki disease. So when he came to us, there was a giant aneurysm, which I have a picture, I'm sure that part. Giant aneurysm, and it was totally filled. The LFC was totally filled with clot, and he already had a mitral infarction, and as a result, he had cardiomyopathy. So he went on for some time, and he probably the parents were very difficult to counsel. And they came back at about 8 years of age. He had a CABG, a graft from the pneuma was taken. He went on quite well, and as Madam was telling, thereafter, at about when he was in high school, at about I think 17 years of age, he was having recurrent ventricular tachycardias. And he used to go to school on the cycle, and he often be found at the roadside in an unconscious state. So he was again brought in, and then we had a ET study done. We could induce the ventricular tachycardias, and he was put in the ICD. Now he is about 23 years old. He is on a regular follow-up post CABG. His graft is functioning well, and he has his AICD has not needed any changes so far in the last about 8 years, and he has been doing very well. The other children, we haven't seen stenosis as of now. We keep a very close watch because the common statement is just after the aneurysm, just after the aneurysmal dilatation, we have stenosis. But until now, we haven't got any stenosis until now. From the international literature, and we have from my other colleagues who have seen, I think, only a few, what they do is, if the giant aneurysm is quite big, and there is another chance, as per the literature says, the chance of aneurysmal rupture is quite rare because it's protected by some coverings and other subcutaneous tissues and the tissues. But if there is a recurrent chance of thrombosis, they put a cover stent. The cover stent is easily available in India, they are very much used. We also use them, cover stents. And the length of the cover stent spans the whole length of the aneurysm. So the aneurysmal segment is converted into a normal coronary artery with the use of the cover stent. If the segment which is stenosed is included within that one, the whole process is normalized. But the child has to be on anticoagulants or antiplatelets rather for the lifelong. So that has to be this. Nowadays we have stents which can be redilated. So even if it's a small child, then if you put the stent, that stent can be redilated to an adult diameter at a later on stage. The third case, which one of my colleagues reported, from Gujarat, he had a small infant with a giant aneurysm with a clot totally occluding the coronary artery. So he went inside, and we have thrombosuction mechanism. So he thrombosuctioned the whole clot, and the clot was taken outside. He didn't publish this case, but he's writing on it. He has a sensitivity scan done 1 year just during the clot formation,
and 1 year after that one, which has shown that the child has totally normalized now, the myocardial function has totally regained, and the myocardium has been regained.
Suppose you have a stenosis in association with the giant aneurysm.
Correct.
Are you comfortable putting the stent in, and will it be different from a patient who does not have Kawasaki disease?
No, the stent will be instituted, and it will be like a normal person. Because after that one, we have eliminated the giant aneurysm. We have put the vein in between the giant, through the giant aneurysm and the stenosis part. So it will be normalized.
But these arteries are also prone to calcification.
Yes, sir.
Does that complicate the picture?
Not really, because calcification can occur, sir, but at the same time, we have to keep a very good watch, and with the calcification can occur, exosomatic calcification can occur only when some of the glass. When we allow the glass formation, so to prevent the glass formation, we try to put the child on antiplatelets and on antiplatelets as well.
Will you be able to prevent the calcification?
Not totally, sir, but the chances of calcification, formation of calcification on the native coronary artery is also similar as on the stent. And if the calcification even occurs and these stenosis occur, we can restent it. It is not if the first stent restenosis, we can always put another stent.
What about road ablation?
Road ablation can be done, sir. In adults, road ablation is done. The only problem we have in children is the sheath size. That means whenever we go inside the heart, usually from children we go to the tubular artery. So the tubular artery has to accommodate that tubular artery. As if the child is a little bigger, we can definitely go for it. If the child is a little smaller, we will try to avoid that. Road ablation is a good part, but absolutely not when the child is a little bit bigger. So for small children, we go for it.
Dr. Devadan.
Come across it was a 7-month-old boy. I will be showing it, but just wanted to mention 7-month-old boy who found with severe cardiac dysfunction and was being treated as dilated cardiomyopathy. But I found that the child, in addition to the severe MR and the severe dysfunction, the child also had an aneurysm of the RCA. What was interesting is there was a flow acceleration in the proximal RCA. And when I did the coronary Dopplers, it came to be seen like coronary stenosis. And very interestingly, the troponins were high, that the ECG was also showing ST segment depression in L03 area. We had started on medications, but before we could go forward for any other intervention or anything, we lost our child to ventricular arrhythmia. And another point that I would like to inform is that he treated along with Dr. Pal and his team that there was this small child of around 6 months or so with giant aneurysm. We gave that whole armamentarium of the primary intensification, and the child showed remarkable improvement when it's been to PGI also, and now the coronaries have become almost small, like most of the aneurysms have regressed, and the largest one is like a small to moderate aneurysm within a span of 6 to 7 months. And that child also had a thrombus initially, had 3 days of admission, and we had put on the antiplatelets and anticoagulants also. 2 thrombi, blocking the LMC, and then maybe we should do it. So these 2 points I wanted to mention.
So again to highlight the management of Kawasaki disease in many patients is lifelong management. And we have to keep on following them, and sometimes you come across surprises and not very pleasant surprises. So with this we come to the end of the oration by Dr. Suda. We thank Dr. Suda for delivering this oration.
Thank you, ma'am, for delivering the oration. May I request Professor Singh and Professor Rawat to present Professor Suda with a token of our appreciation for delivering the Professor Lata Kumar lecture. Thank you, sir. Thank you, ma'am. Thank you. May I request everyone to join us for a cup of tea in the foyer? Thank you. We'll assemble in 10 minutes sharp, please.